Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
This film demonstrates the periodontal treatment of an infrabony pocket involving the maxillary premolar. A soft tissue crater remains between the canine and first premolar. Distal to the first premolar, a rather deep defect is observed. A Hirschfeld silver point has been inserted in the lesion. The infrabony part of the defect is 6 millimeters from the crest of the bone to the base of the pocket. The pocket depth on the buccal surfaces of the two premolars is not as great as that interproximally. The teeth have been initially prepared by scaling and root planing. Occlusal adjustment has also been completed, and the patient appears to be maintaining good oral physiotherapy. After infiltration anesthesia has been obtained, a vertical releasing incision is made at the distolabial line angle of the maxillary left canine. And at the distal buccal line angle of the second premolar. The two interdental papillae are separated from their lingual halves, and an intrasulcular incision is made. A number 11 Goldman-Fox instrument further separates the buccal and lingual papillae. Periosteal elevator is used to reflect a full-thickness flap to gain access to the osseous deformity. Care is taken to see that the flap is not torn in the reflection process. As the flap is reflected, it is possible to see the bony defect which is distal to the first premolar. Using a Goldman-Fox number 4 curette, soft tissue tags are removed from the infrabony defect. The curette is placed into the defect and passed from palatal to buccal, removing some of the soft tissue fibers that are adherent to the osseous tissue. The area is irrigated. A palatal flap also will be reflected, and probing shows the depth of the defect from the palatal side. A vertical incision is made at the distal lingual line angle of the maxillary canine and the distal lingual line angle of the second premolar. The periosteal elevator is again used to reflect this tissue and expose the infrabony defect. Soft tissue tags are removed. The curette is used to clean out the osseous defect. Care is taken to see that all surfaces of the involved teeth are free of calculus and debris. The apical part of this infrabony pocket has 3 osseous walls, a buccal, a distal, and a lingual wall. The coronal portion of the pocket has but 1 wall remaining, the distal wall. Any remaining calculus and soft tissue tags are removed, and the root is thoroughly planed. The base of the pocket, having 3 osseous walls, will be amenable to new attachment. The probe now enters the 3-wall part of the defect, which is at the very base, and shows the presence of a buccal plate, the distal wall, and a lingual wall. As one moves coronally to the buccal and lingual plates, only the distal wall remains. This, therefore, is an infrabony pocket with 3 osseous walls at its apical portion and 1 at its coronal portion. In order to reach the periodontal ligament, which is one source of repair tissue, the tissue apical to the epithelial attachment is removed. Intramarrow penetrations will be made through the sclerotic alveolar wall to provide another source of repair tissue. Using a number 1/2 round burr, these intramarrow penetrations are carried into the distal wall of the defect, allowing the marrow tissue to ooze into the area. The openings permit the connective tissue of the marrow to proliferate into the osseous area. Marrow is a tissue with a high osteogenic potential. Note how the blood and marrow tissue are filling the 3-wall part of the defect. This is desirable because the blood clot will help reattachment to occur. Care is taken not to aspirate this material. The buccolingual flaps are pulled closely together and sutured in position. In the 3-wall portion of the lesion, reattachment with the formation of new ligament, cementum, and alveolar process is anticipated. The area over the orifice of the pocket is covered with an inner lining of adhesive dry foil. The use of foil between the premolars will prevent the periodontal pack from being pushed into the infrabony wound. It will also serve to protect the underlying blood clot. A periodontal dressing of the Baer-Sumner formula is placed over the buccal and lingual surfaces and locked interproximally to enhance its retention. This is then reinforced with the Kirkland pack. Adhesive dry foil is placed over the periodontal dressing to protect this area during healing. The pack will be changed several times at weekly intervals. 3 weeks post-operatively, the tissues appear to be healing well. Probing indicates that shallow sulci are present and the tissues are filling in. An aid splint will now be placed in the occlusal surfaces of the molar and premolar amalgam restorations to stabilize the teeth. This twisted wire splint will be embedded in a groove, which is cut antero-posteriorly in these restorations. An inverted cone burr is used for this purpose. If possible, the groove should be placed in a restorative material because the wire will be covered with a plastic, and the restoration will prevent any pulpal reaction from the plastic. A .015 dead, soft, twisted wire is placed into the groove and cut to the proper length. This type of twisted wire splint serves as a temporary means of immobilization. Wedge-shaped wooden picks called stimulants are placed interdentally between the teeth. They prevent the plastic from obliterating the embrasures, which would impair the patient's oral hygiene technique. Plastic is placed in the occlusal groove and the twisted wire is seated. The wire is covered with a quick-setting plastic material which is applied with a brush-on technique. This type of splinting usually is accomplished prior to the treatment of the infrabony pocket, or, as in this case, due to orthodontic considerations, immediately upon removal of the surgical dressing. After the plastic has polymerized, the occlusion is adjusted. The premolar no longer has a mobility pattern when checked for buccolingual displacement. A more permanent type of restoration will be constructed in about 4 to 5 months. It is now obvious that there is no mobility pattern present in these teeth. This radiograph was taken 2.5 months post-operatively. The Hirschfeld point, which goes to the base of the sulcus, is now above the crest of the bone. It is apparent that the epithelial attachment is in a more coronal position than it was preoperatively. A 3-month post-operative radiograph shows repair of the osseous defect on the distal surface with bony regeneration taking place. A periodontal probe used on the distal aspect of the first premolar shows a 2 to 2.5 millimeter sulcus present in that area. The papilla has the flat, saddle-shaped form.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.